And now we have six case-based discussions. And to begin the session, I would invite for the first case, which is a discussion on basically neurocritical care and nutritional stewardship in neurocritical care. So moderator is Dr. Deepak. I would request Dr. Deepak to take the podium, please. And to join in as the panel, I would invite Dr. Dilip Datta, consultant neurosurgeon in NSC Chowda. I would like to invite Dr. Shobhitra Chaudhary. I'd like to invite Dr. Mridul Bera and Mrs. Shatavisha Basu and Mrs. Shormishta Gui.
Thank you, Doctor, for such an informative session. So, without further wasting of time, we'll go for the first session, which is nutritional stewardship in a neurotrauma patient. So, this is a case history in which the first case in which a patient named Aniket Manna, aged 15 years, had an alleged history of fall from second floor of a building. He was brought to the ER with a GCS-8 with sluggish reacting pupils. Patient was promptly intubated and put on ventilator. CT scan was done, which revealed right subdural hemorrhage. Spinal MRI revealed L3, L4 and L5 fractures, and chest X-ray showed fracture of 4th and 5th ribs. Initial ABG revealed metabolic acidosis with lactic acidosis, which progressively deteriorated. Patient was resuscitated and shifted to ICU. Patient underwent right frontotemporal parietal decompressive craniotomy next day, and patient was nil pump mouth pre-operatively and was in IV fluids at the rate of 100 ml per hour. Rise to feeding was initiated 4 hours after being shifted to ICU at the rate of 440 ml per second hourly, with total of 9 feeds on POD0. Next day, feeding was increased to 80 ml per hour with total of 18 feeds, which roughly came to around total energy of 977 kilocalories and protein of 37 grams. Meanwhile, women received 3 units of PRBC, 4 units of SFP, and 6 units of cryo. POD1 and 2, the GCS remained same, that was around 7 to 8. So, before we move further, my first question would be, what are the different methods of nutrition assessment? If the dietitian in our panel could help us.
When this patient comes to when this patient comes to the ICU, first we do the nutrition assessment within 24 hours. There are many nutritional tools available. In our hospital, we mainly follow NRS 2002, that is Nutritional Risk Score 2002. It is a well-validated and simple tool designed for pre-screening any questionnaires. We are firstly check that if the patient is a food intake for last 3 months is reduced or not. For the loss, in the case of loss of appetite, any digestive problem or any chew or swallowing problem, is the patient weight is reduced for the last 3 months, and we check the patient mobility, and the patient next we check the patient BMI. If the BMI is low, then patient is malnourished. In this case, we start as an internal nutrition firstly, as per here recommended that 40 hours second hourly. So we the calorie is 30 to 35 calorie per kg ideal body weight as per ASPEN guideline, and from 1.2 to 2 gram protein per kg ideal body. Initially we start calorie and protein is 977 calorie and 37 gram protein. Gradually we increase the calorie protein and when the patient is fed 80 ml per hour 18 feed, first we provided 977 calories. Next we increase the calorie as per patient case. Thank you.
So very well said by Samishta. So suppose this patient comes to the ICU. So if we consider the role of early versus late initiation of feeding, what would be your say?
So within 24 hours we start internal nutrition, because late feeding started, that means there is a longevity stay in the ICU is increased. So as soon as possible, within 24 hours, we start as a tropical feeding, that is 10 to 20 ml per hour, and started should be provided minimum 500 calorie and 10 to 12 gram on the first day.
Further, what would be the carbohydrates, fat and protein goal for this patient? Sir, if you could throw some light.
Sir, as per guideline, we already suggest that 30 to 35 calorie per kg ideal body weight is recommended, and protein should be increased by 1.2 by 2 as per patient condition. Day by day, calorie and protein should be increased.
So the case is an interesting. The case is an interesting one. This is a head injury patient. So the first of all, when you start the patient with the nutrition therapy, first of all you have to stabilize the patient. So first is the stabilization of patient is important. Suppose the patient is having these multiple injuries or head injuries. If the patient is hemodynamically unstable, we cannot start the initiation of nutrition. So first of all, after stabilization of therapy, we can definitely initiate the therapy. So then when we initiate the therapy, definitely assessment, the nutritional assessment of the patient is definitely very, very critical. So if you go the assessment score, there are different scores that you have been adopting. You can go for this, the NRS, the 2002, or you can go for the Olympic score. First of all, you have to identify whether the patient is what is the severity of the patient and how much nutrition is patient needed. And then after the assessment, if the patient needs the patient is having a severely disabled patient, you need definitely the therapy. And between the therapy, whether we go for the enteral nutrition or we can go for the parenteral nutrition for the peripheral, that is really important. So most of the cases, the enteral nutrition is preferred the worldwide, whatever the patient is having. So if there is any contraindication of enteral nutrition, suppose the patient is very severely ill, patient is having severely malnourished, in that case you can start the patient the parenteral nutrition for the very first. Otherwise, we have to give the patient the enteral nutrition. So the first, say the 24 hours, we have to give the patient at least 70% of the total calorie. Then up to 7 days, you have to give the 80%, and after the 7 days, you can go to the 100% of the total calorie. So the thing about why the enteral nutrition has been preferred over the parenteral nutrition, there are various papers which support the enteral nutrition is better because the gut is a factor. When the gut is you can say the one of the thing that will be the very vital, because if you do not treat the gut with an enteral feeding, it will definitely causes the disorganization of the gut integrity, because from that part the infection can be increased, or you can say the immunomodulating system will be improved with the gut stimulation. So the enteral nutrition has been preferred over the parenteral nutrition. So in this case, I will go for the enteral nutrition first. Then you have to consider whether the patient is after giving the patient the enteral nutrition, you have to wait for at least 72 hours. If we could not achieve the 70% of the total calorie, that as you have said, that's the most of the recommendation is 20 to 25 kilocalories of ideal body weight. For the calorie requirement, if you go for the protein intake, it should be 1.2 to 2 gram of protein. If you could not achieve the within 3 days the 70%, then you can go for the enteral nutrition. Otherwise, always go for the enteral nutrition first.
So very rightly say that they should initiate this enteral feeding as soon as possible to prevent complications like serial diarrhea and VAP. So this patient on POD2 develops IBS, abdominal sounds were reduced, and patient had an NG aspirate of around 150 ml. So how should we proceed for this patient? Shall we continue with the NG feed, or what should be the further plan of management?
So, if we consider NG aspirate, there are some papers which have already shown that the amount of NG aspirate does not always correlate well with the chance of aspiration. Okay, so, but I should take from Dr. Anirban's last slide take-home message that one size does not fits all. So we should properly assess whether the amount of NG aspirate and what is the amount of NG aspirate and whether it is coming in every feed and whether there is bowel sounds are present or not, and whether we can overcome that by placing the feeding tube down the leg in the jejunum. So if we can do a feeding jejunostomy, we can place the enteral feeding down the leg. But still, if the patient is having ileus, then even if we place the tube down the leg, it will not be successful. So we will have to tailor our practice based on that.
Sir, do you think there's a role of prokinetics in such patients?
In these cases with polytrauma, especially with head trauma, there is a period of gastroparesis which begins on the day following the injury and lasts for about 72 hours. Many of us have used IV liposulfuride in this setting, but before starting prokinetics, I think since the patient also has a spinal injury, we should rule out anything in the abdomen. That is, an abdominal imaging needs to be done to figure out whether there is any physical cause for the ileus, whether there is any local perforation that might have been missed, or whether there is a retroperitoneal hematoma that we might have missed that may be causing obliques or something like that. So, further investigations before we take the call on prokinetics.
Thank you.
Just I want to add, talking about the gastric residual volume, which is very critical. There was some paper, if you go if the gastric residual volume is more than 300, you should abstain from giving from the intranutrition. This is not true. There are various papers. In fact, if the patient is having gastric residual volume up to 500 ml also, you have to feed the patient. Because if there is no absolute contraindication, like that you can do abdominal distension in there is a vomiting, there is a reflux, you have to continue the enteral nutrition in a trophic manner. It's a small amount, but you have to continue it.
So, I would like to add something.
One more point is that all these patients who have suspected gastroparesis or suspected polytrauma, abdominal trauma along with the head injury, during intubation we should be routinely using those endotracheal tubes with suction ports, supraglottic suction ports, so that if there is any occult aspiration happening, that can be taken care of inside the airway itself. A normal AT tube usage is not a concern.
Sir, if gastric residual volume remains to be more than 300 for 3 to 4 hours, then we should still think of continuing the injective, or we should shift to our parenteral nutrition.
Now, actually, the thing is that how you can assess the gastric residual volume. It is not always the suctioning the patient. You always have to just suck the patient by the syringing. So you have to assess if the patient is more than 300. You can definitely consider whether you will just abstain from giving the patient the intranutrition. But the thing is, if there is relative contraindications for enteral feeding, not the gastric volume, not the residual gastric volume, but other things you have to consider, the abdominal distension, nausea, vomiting, the passing of plaque stool, then you can consider about giving the patient parenteral nutrition. Parenteral nutrition will always be there. If there is no absolute contraindication, you have to give the patient the enteral nutrition. And because in standard protocol is that you have to go for the enteral nutrition for at least for 7 days. Then after consideration, if you could not achieve these goals, then you can have to give the patient the parenteral nutrition. Up to 7 days, if there is absolute contraindication, then you have to give the patient from enteral to parenteral nutrition.
Thank you, sir. So, what would be the role of gastric versus post-spinal rise to position in such patients? Which are told already, but
That's what I was talking about. So we can either place the RAS to post-pyloric, or we can do a jejunal feeding tube. If we find out that there is no significant ileus, the bowel sounds are present, but still adequate amount, a significant amount of gastric fluid is coming back. So then we can use this type of thing.
Parenteral nutrition usually entails an IV infusion of a large amount of fluid that contains a lot of things that will be metabolized. So it will be a large hypotonic infusion and has the potential of increasing brain edema. So when a patient has undergone decompressive craniectomy for the first few days, I don't think it is advisable, and enteral is probably the only way to go.
so what is the role of parental feeding in such patients, in such conditions? It has been already told by Dr. Midul Dara. So I move further to the next question. Any adjunctive therapy we would like to follow for any severe or brain trauma patients?
This is a very good question. So now talking about the enteral feeding, so there are various methods of giving the enteral feeding. There is various formula, particularly the small heart syndrome. We are giving the patient the blenderized, that is the formula, that is the homemade or hospital based food. So there is a competition, there is a difference between if you give the patient the blenderized formula and if you give you the specialized formula, the special formula, that is the specially made formula. And what is the difference between these two? The problem is if you go for the blenderized food, that is you have to add in the food, the calories, there will be a deficiency of calories, deficiency of the protein. So we will not encourage that type of feeding because that will also go on to add the infection because there is a chance of infection. There are various papers. There are papers from Iran, there are papers from the Philippines, but that is when if you go for the blenderized food, in this situation, there is the more chance of infection. The gut infectivity will be lost, there is the more accumulation of infection, there will be the most, the sepsis will be increased. So we will go for the special formula, that is the specially made formula. So when you just go for the special formula, you have to rely on the which formula. So in the standard protocol, you have to give the patient the polymeric formula, the polymeric enteric formula, where there will be the mixture of the carbohydrate, fat, protein, and also the micronutrients will be there. Because that is the added benefit of giving the special formula. Because you do not have to add anything. Micronutrient will be there. There is the volume. The patient will need the caloric, the dense calorie, the volume. So we can give with the special formula. And something that is apart from the standard polymeric enteric formula, there are different types of formula that has been added. Suppose the formula has been added, the immunomodulating agent has been added. Some formula has been the diabetic specific, disease specific. Disease formula is available. In terms of the CV or the brain trauma patient, there are some papers we can give the immunomodulating agent added to this polymeric enteric formula in the form of you can go for the EPA, DHA or the arginine. But the thing about it, when you just add these special substances, so there is not such a benefit that has been obtained with adding this formula. But if again you can add, suppose that you can have the patient you can have the prebiotic or the probiotic along with this polymeric enteric formula. But the paper is showing by giving this immunomodulating agents, by giving the prebiotic, probiotic or the polysaccharide or inulin, you do not get any added advantage. There are some papers that we are definitely getting the advantage, but most of the paper we are not getting advantage. So in terms of the severe the brain trauma patient, we have to give the patient the polymeric enteric formula first, and if the patient is not improved in the latter part, you can add the immunomodulating agent.
And there is role of antioxidants.
Yes, there is also some paper of oral antioxidant in the special enteric formula. But again, the paper is showing that in some of the paper that is we are getting the advantage of especially the giving the antioxidant, and some paper is showing not. But again, I think the standard formula, you should give the standard formula first, then you can think about it if the patient is not improved.
Okay. So the recent advances pertaining to neuro patients.
A lot of these cases will require long-term nutritional support. They will be in the hospital for a very long time. So the problem arises when we have a patient who is vegetative, stuck on BCS9, not able to feed, and there is an NG tube which is gradually eroding into the nasal septum. So how early do you go for a surgical feeding tube? That is a PEG or a vaginostomy or something like that. So probably we can have some discussion on that topic.
And not only that, our brain trauma patient sometimes comes as a polytrauma patient, but so which already do, whether there is any abdominal trauma, and mainly the facial trauma patient. Establishing a Ryle's tube in a facial trauma, and even a patient having skull base fracture. We have already seen scans where the Ryle's tube is through the skull fracture going inside the brain. So ACL trauma patient as a polytrauma with head injury are notorious. So in those patients, probably we should go for early jejunostomy, rather gastrostomy, jejunostomy, whatever, rather than going in for a Wright's tube or neglecting the oral route, because the patient is having ACL trauma. Sometimes we neglect the entrance. This patient cannot. How can we put Wright's tube? So we cannot just wait for Wright's tube. We can go in for surgical treatment procedures.
Okay, thank you. Thank you everyone for such an informative session with us. So before concluding the session, any question from the audience? Okay, then we'll follow up. Thank you.